Hello, everyone. It's yeah. Hello, everyone. Good morning, good afternoon, good evening to all. Thank you for joining us today, and thank you for POCUS it's a Certification Academy to having me here, and thanks for all their great effort that have made this possible for us to have such this great webinar and talk about the point-of-care ultrasound. Let's introduce myself briefly. I'm Dr. Abdulkader, emergency medicine specialist, board certified emergency medicine physician. I'm founder of Master Academy. It's a free educational website that you can go through. The code that I put here is a free website, and you may find some content, beneficial ones in emergency care, hopefully. Today, so we're not going to talk about use of applying, point-of-care ultrasound in critical care, in sepsis, in shock, in CPR. We're going to talk about the POCUS in something maybe seems like it's not the critical, but if you miss it, so it's up with some critical sepsis and bad outcome for the patients. For me, as an emergency physician, always when I am thinking about highest quality care, the POCUS comes to my mind, because for me, without the POCUS, I always question myself how I can give the highest quality of care and how can do my best for the patient, because sometimes our hands has some limitation and we cannot detect every sicknesses, every pathologies, just using our clinical skill, our physical examination. That's why we need to add something extra, some extra ability like the POCUS, just to have to be able to go through the body and see what's happening under the skin. What we will talk today is about POCUS in the soft tissue infection. So we will discuss about what is the challenges that you may have in our physical examination when you are facing with a patient with soft tissue infection, and how POCUS acts like a game changer in these cases and sharp our scale, our clinical scale, our physical examination, and then we will discuss about the scanning essentials, what we should consider before running point-of-care ultrasound in a soft tissue infection, and what is the key ultrasound finding in the normal soft tissue, and also patient has cellulitis or abscesses, and what red flags that we need to search for them, look for them. If you found them, so means more critical case, more serious case, and we need to be more invasive in treatment of such these cases. The pitfalls we need to consider in point-of-care ultrasound, and finally, so we will sum up our discussion, how we can approach a soft tissue infection in emergency room or also in ambulatory setting. So this discussion is not just for emergency room. Every clinician, they can use it in ambulatory setting, critical care, maybe ICU or emergency room. So when you are talking about soft tissue infection, so usually a patient present with warmness, redness, pain, and the swelling, and some of them, they have the fever. But this presentation always, it's not like just one sickness. We have different types of infection that when you're talking about the soft tissue infection, we talking about them. For example, cellulitis, abscesses, necrotizing fasciitis, or pyomyositis. So all of them, they may come with this presentation: warm, red, pain, swelling, and the fever. If these cases come with typical presentation, maybe it's easy to diagnose with just clinical examination. But when it comes to some atypical cases, so we miss some of them if you don't use point-of-care ultrasound. So clinical examination is not enough for all the cases. Here, if you see here, for example, in this one is typical, there is an abscess, and this one already drained is abscess, and here looks like cellulitis, and this one more critical could be necrotizing fasciitis, and this one could be cellulitis or pyomyositis. So these typical cases, textbook presentation is easy to diagnose. But as we discussed it, so if it comes to some atypical cases or early stage of some infection, we cannot trust just our palpation. If the patient has this very small and deep abscesses, or the abscess is under thick fat, or persistent induration, or persistent scar, or the abscess inside the muscle, so our clinical examination, our hands cannot detect this kind of infection. But if you have a POCUS, point of care ultrasound, or ultrasound, you can go through the body and see under the skin and diagnose all these cases. So when you miss an abscess, means you miss drainage, the procedure the patient really needs. And if you miss the treatment, means worse outcome. So what is the solution as we discussed it? POCUS is the solution. POCUS bridges the gap. And thanks for the POCUS is immediate, bedside, and non-invasive. This picture that you see, it is one of my patients few days before I saw in emergency room, came with just a little redness, warm, and a discomfort, a little, but not through pain. Patient was on tramadol and antibiotics for another reason. So looks like for me cellulitis. By default, I just went to perform the POCUS for this case, and I found something very unexpected for me. So it is the clip of that ultrasound. You can see here, there is fluid accumulation, looks like cobblestone pattern that we're always talking about cellulitis. This one comes to our mind. And I just search more and assess more the case. I found something unexpected. If you see here, this one is a normal site, and this one, it is abnormal site. If you see here, there is a small effusion around MTP1. So it looks like maybe arthritis. So patient but doesn't have a pain because he was on tramadol antibiotics. So it comes with some atypical presentation. So we aspirated, and the diagnosis looks like arthritis. But if I didn't do the POCUS for this case, so I'm not sure so what's happened to the patient and what outcome we will expect it in these cases. So it is the rule of point of care ultrasound in our care. So POCUS actually improve abscess detection. So we can identify abscesses that misses in physical examination. And per the studies changing our management in over 50% of emergency cases, has very good positive predictive value and negative predictive value. And actually performing the POCUS is not just to find some pus under the skin. Sometimes we need to make sure there is nothing else, like maybe DVT, so the aneurysm, or if the skin of this redness and erythema over the joint, maybe there is a joint infusion, such that case that we reviewed together. And fortunately, it works in both pediatric and adult setting. Per the study, POCUS changed management in 17 to 56% of the cases. And in up to 58% of the patient with low likelihood of abscess formation, they detected abscess. And using the POCUS, add the positive predictive value from 81% to 93%, and negative predictive value from 77% to 97%. So if you are doing the POCUS, means you are avoid unnecessary procedures, and actually fever means drainages. Sometimes we feel there is abscess, but when you're doing the ultrasound, we cannot find abscess. So if you don't do the point of care ultrasound or ultrasound for this case, so you may go for some procedure, incision and drainage unnecessary. Per meta-analysis that has been done 2017, sensitivity of point of care ultrasound 96% is reported, and specificity 83% for abscess. So point of care ultrasound, it is really game changing for detecting early infection, deep infection, and some atypical cases. So how we need to do ultrasound? When you are going for the ultrasound, first of all, always you're thinking which probe we should select. So in soft tissue infection, we are checking superficial layer. So for the superficial layer, we need to use high frequency linear probe. So ideal for the skin and soft tissue, they have a good visualization, give us good visualization. But if you want to check for something more deep, more than 4 centimeters, so better to use low frequency probe that have better penetration. For example, if you wanted to look for abscess formation in thigh, buttock, or pyomyositis, so you need to use low frequency. So which probe we need to use in soft tissue infection point of care ultrasound? Both of them we should use, and depends on the cases. If the case is just we are looking for abscess in under the skin, very superficial and shallow structure, so high frequency. But if you wanted to use curvilinear probe, so if you wanted to look for more deep structure, low frequency probe are the best. If you are doing the point of ultrasound, for some cases maybe they have wound or post-surgery, post-op cases, or you are doing ultrasound over some sensitive structure like the eyes, better to use barrier protection for the probes like tegaderm, cover, or gloves, just to prevent the contamination, reduce the risk of infection, and maintain sterile environment. For optimal scan, in soft tissue infection, we need to use more gel because just wanted to bypass the dead space. The dead space is the space between the probe and the body. The body. So we may miss 2-3 centimeters of the 2-3 millimeters of the skin sometimes, but for superficial abscesses, just to not miss them, you need to use more gel or use stand-off pads. Or if you wanted to scan very tiny structure like toes or fingers, you need to use butter bath. So we just need to hold the body, the hand, for example, or foot under the water and do the point of care ultrasound in distance of 1 centimeter over the toe and the finger, so we can have better images and we don't miss any abnormal finding. Always when you are doing the ultrasound, it is a rule in ultrasound, we need to check transverse and sagittal plans in both sides and scan all and hold the lesion to not miss any part of them, because if you find some abnormal finding and if you finish your exam soon, you may miss another pathologies also. That's why it is recommended to do full ultrasound in both transverse and sagittal and map whole lesions. Using colored Doppler is very important in soft tissue infection, just to locate vessels, distinguish between abscess and the lymph nodes that we will discuss later, differentiated between blood vessels, and identify adjacent vasculature. So with colored Doppler, we can just map the structure around the abscess, around the cellulitis. If you wanted to do, for example, the procedure incision, you avoid from hurting these organs. Adjusting depth and the focus is very important. So if you wanted to just scan, for example, 2-3 centimeters, you need to adjust the depth for maximum 3-4 centimeters, just to focus on the area of your interest, to have more details from that part that you want to scan. And actually, the focus should be fixed under the area of your interest to do better measurement and more better visualization. So we discussed about the importance of the POCUS, how it is important to use the POCUS. If you don't use the POCUS, how we may miss atypical cases or early stage of some important infections. And then we will discuss about how set our device, our machine, which probe we should use, and what is the best probe. Depends on the location, the anatomical location of the body, different people, different body habitus, and actually we talked about the depths and also we talked about the focus, the gain. So we need to adjust all of them to have a better images. So before going to discussing abnormal finding in soft tissue infection per the ultrasound, let's discuss the normal ones. If you understand the normal ones, so we can also detect abnormal and pathologies easier. So when you are doing the point of care ultrasound, we have different layers. Maybe it's a little confusing firstly, but it is easy, I think, to learn. The first layer is very tiny hyperdense layer, epidermis and the dermis. And then below the epidermis, dermis, there is subcutaneous fat with some hyperdense lesion, hyperdense structure inside that one. And then fascia, and then the muscle, and then you may have you have bone, very hyperdense bone with posterior shadowing. So the normal ultrasound finding, it is epidermis, dermis, fat, fascia layer, and the muscle. And as we are scanning different anatomical locations, you may have different structure. Maybe we have two muscles over each other, or sometimes we have just one muscle. So knowing the normal pathology is very important, that we need to keep in our mind. So let's discuss about the pathologies. So what we should look for them in soft tissue infection. We will start from cellulitis. So cellulitis is the infection that involves dermis and subcutaneous fat layer. Just because of inflammatory mediators, the capillary permeability will be increased and leading to intralobular edema between fat lobules, and we have lymphatic congestion, hyperemia. So these result in skin worms, tenderness, and pain. So because of these pathologies that happen, these inflammatory markers and capillary permeability increasing, so we have soft tissue edema that in ultrasound we can find. In cellulitis, what we should look for, it depends. What is your case? It is the early stage of cellulitis, or it is advanced or developed, like a true cellulitis. If it's early stage cellulitis, you may have skin thickening. So how you should know this skin is thickened or not? So we need always compare with the normal side. What I usually do when I have soft tissue infection case, so I usually do the point of care ultrasound for the normal side firstly, and then I will go to abnormal side just to compare skin thickening to see it is normal or not. And at the next stage, we have changing in echogenicity. So subcutaneous layer is hazy and bright when the abscess progressed. And then we have differentiation, poor details of normal tissue layer. That's why we discussed the normal layer. But in case of cellulitis, so we cannot differentiate different layers of the skin. And finally, in advanced stage of cellulitis, we have cobblestoning, a classic sign of the cellulitis because of the edema that separated fat lobules. But remember that cobblestoning is not specific just for cellulitis. We have cobblestoning in other non-infection cases also. And you may also have enlarged regional lymph node that we should take care of that. Take care of them. So not mistaken by abscess that we will discuss about them here. If you see in this image, there is a hyperechoic dermis, and then hazy skin thickening that you can find in it is early stage of cellulitis. Here, if you take a look, here is a normal skin, and here it is cellulitis. If you see here, there is a dermis layer, hyperdense, and subcutaneous layer, and the fascia layer, and the muscle. Just compare this side, the abnormal side, with the normal side. It's clearly we can see that there is a skin thickening, and so it is early stage of cellulitis. At the same time, you can find some fluid accumulation in subcutaneous layer, so it's early stage of cobblestoning stage. It is a typical case of cellulitis. And here, the appearance of cobblestoning, typical cobblestoning. You can see here fluid accumulation and fat levels, and the fluid just separated the fat levels. It's a typical case of cobblestoning. So talking about the cellulitis, it was detecting skin thickening, detecting the layers, we can differentiate all of them or not, and also the cobblestoning and fluid accumulation in subcutaneous layer. So let's go for abscess. In the abscess, what we have fluid accumulation, pulse accumulation under the skin, some granulation tissue around the abscess, and actually we have a normal fat maybe or a pyogenic membrane around the abscess. So the abscess is fluid collection with a border. Just in the abscess, we don't have just one unique pattern. You may have some abscess with an echoic pattern, black, or some of them maybe they have debris, heterogeneous or homogeneous appearances. So different abscess, they have different appearance, and there is a rim of echogenic around the abscess sometimes. Sometimes we have rim of cellulitis. Some of them, they are well circumscribed, or some of them, they have irregular border. If you see here in this video, so there is a border, there is a dermis, and there is a abscess just immediately under the skin, and there is some debris inside this pus accumulation. So it's a typical case of abscess. So one good landmark in detecting abscess is posterior acoustic enhancement. So because of the abscess filled with water loves ultrasound like us. So water enhance, fluid enhance transmission of sounds. So that's why we have brighter appearance at the posterior side of the abscess. So it's a good landmark just to differentiate abscess from other lesions like lymph nodes or cysts. Another good landmark that we need to check for it in detecting the abscess when you are not sure about it is abscess or not, it is squish sign. So when you are putting some pressure on the skin, you can find some movement in the pus. It is squish sign, and it is a good landmark again for differentiated abscess from other non-infection lesions. So let's review some images related to the abscess. As you see here, there is the hyperdense dermis, the subcutaneous layer, and here we can see irregular border and heterogeneous appearances of an abscess. And here it is another abscess that circumscribed abscess with heterogeneous debris here. And if you see here, there is an abscess with cobblestoning. So if you find cobblestoning finding picture in your ultrasound, doesn't mean there is no abscess. We need to look for another size also, just to scan all the adjacent organs to make sure there is no abscess. And if you see here with the color Doppler, we have hyperemia, so means inflammation. Another abscess you can see here with irregular border, and there is a very mild effusion here, looks like cellulitis. So abscess may have also cellulitis at the same time. Another abscess we can see here with irregular border and more homogeneous appearance. And here it is very superficial abscess. It is the dermis, and just immediately under the skin, under the dermis, you have very small abscess, superficial abscess. So if you don't use enough gel, you may miss this one, or standoff pad. So if you may miss these abscess. That's why we prefer to use more gel in soft tissue ultrasound. Another application of ultrasound is detecting sometimes, find some finding in support of osteomyelitis. So if you find abscess or fluid accumulation just over the bones, so it could be indicative of osteomyelitis. If you see here, there is a fluid accumulation, pus accumulation over the bone, and there is some bone erosion here, and they put the color Doppler on the bone. Here the abnormal side and here the normal side. In the abnormal side we can have some color flow. Here means hyperemia and inflammation. So these kind of ultrasound indicate maybe it is osteomyelitis. So abscess adjacent to the bone should be considered more serious. So maybe it is osteomyelitis, and we need to involve related specialists to do further maybe investigation and diagnose osteomyelitis early. So why we have to use color Doppler in assessing abscess? So one of them, so just to see there is inflammation or not, but the main aim is not that. So we wanted to use the color Doppler just to map adjacent organs, or maybe this lesion that we find, it is like, for example, pseudoaneurysm. If you see here, it is a case IV drug users, so came with the redness over the groin, and then they found pseudoaneurysm here with color Doppler. But if you don't do the color Doppler, you may go for aspiration and worse outcome with the pen and turn out with worse outcome with the patient. So when you find a lesion, you need to measure what you find. So you need to record the depth of the lesion, and also the length, the width, and the height of the lesion. And always we need to record what we find just for medical legal issues. So we need to record our images and measure them, and record it in the file. So for the measurement, you need to record the depth, length, width, and the height. So what's the usefulness of the ultrasound in clinical part? So it's not just detecting pus, as we discussed it. So when you find irregular or tracking abscess, it means maybe it is more or resistance infection. So we face with more serious cases. And as we discussed before doing incision and drainage, so we need to map adjacent organs to avoid nerve, vessels, and bone during the procedures. And for follow-up also, ultrasound is very good tools. If patient has a cellulitis with just subcutaneous thickening, so maybe a short course of antibiotic is enough. But if you have cobblestoning, means more advanced cellulitis and slower response, so maybe you need to continue your antibiotic for long term. And also, if you find an abscess, irregular and very small and hard to see, it is 7 times more likely this abscess is due to MRSA. So doing the point-of-care ultrasound is not just for finding pus under the skin. So we can use it in our diagnosis, in our procedures, and even in choosing what's the best antibiotic for this case and how we can follow the case safely with point-of-care ultrasound. So one thing that we need to consider in doing the ultrasound, especially for abscess, it is abscesses mimickers. One of them is lymph nodes. Lymph nodes visually oval and well-defined shapes, uniform ecotexture, and they have a very echogenic structure. It's called helium inside the lymph nodes. And sometimes if it is inflamed lymph node, we may have internal vascularity inside the lymph node that we don't have this finding in abscess. And another mimicker is cyst. Cyst usually is well-defined structure containing fluid. The most common of them, it is epidermoid cyst. how we can differentiate cyst from the abscess. So usually cysts are well defined and more uniform compared to the abscess. If you just push the cyst with the ultrasound, it is movable, but abscess, they are not movable. We cannot move them. And another one, the squish sign that we discussed before, in the cyst, we don't have any movement in the pus, but if you push, put a pressure on the abscess, you can see the movement of the pus. So in this way, we can diagnose, we can distinguish cyst from the abscess. Yes. Is okay? Yeah, sure. Okay, sorry. Um, so right now it's okay? Yeah, yeah, thank you, thank you. Yeah, sorry. Yeah, okay, so when you're doing the point of care ultrasound for soft tissue infection, so our goal is not just to find the pus. So sometimes we need to search for the reason. And one reason for cellulitis and abscess is foreign bodies. So it's more common in pediatric, and with X-ray, so we cannot identify radio-opaque objects. When you are doing the ultrasound for soft tissue infection, cellulitis or abscesses, so that's why we need to search for the reason, and you may find some foreign body, some reason for this abscess, for this cellulitis. So if it is clear per your clinical examination, clinical finding is absolutely, for example, cellulitis, but still I prefer to do the ultrasound in my bedside, just because maybe I find something that helped me to manage my cases better. So how we can see the foreign bodies? If you see here, there is a wooden splinter and fluid abscess accumulation around these wooden splinter, and with some shadow behind that one. Different foreign bodies, they have different appearances. So for example, for glass, we have hyperechoic with posterior shadowing, with sometimes have cometail artifact. So it is a common appearance for glass as a foreign body. For the metal, so we have very hyperechoic lesion, very hyperechoic object that often has a cometail or reverberation artifact. And in wood, so we have hyperechoic with posterior shadowing. So ultrasound appearance of foreign body, it is based on what is the object, based on their composition and material. So doing the ultrasound, it's another reason for doing ultrasound in soft tissue infection is to detect any reason, like maybe there is some foreign body, even the patient doesn't know about that one. So another mimicker is angioedema. So how we can differentiate angioedema from cellulitis? There is very limited evidence suggests that sonographic finding maybe differ between like angioedema and cellulitis. In angioedema, what we can find more linear. If you see here, the fluid accumulation more linear, horizontal, and striated bands. Unlike in cellulitis, there is no like a specific pattern. Some of them there is linear, or some of them oblique. So in angioedema, so more structured, more linear and horizontal and striated bands. So there is very limited evidence that suggests in this way we can differ between angioedema and cellulitis. But as a rule, always we need to coordinate what we find in the ultrasound with our clinical finding. For example, if the patient has a fever, so it's most like infection causes for that case. So always we need to interpret what we find in our ultrasound coordinate with our clinical finding. Another very important and very critical soft tissue infection is necrotizing fasciitis. So can we diagnose necrotizing fasciitis with the ultrasound? Let's firstly say we don't do ultrasound to rule out necrotizing fasciitis. So we should not think about that. We are doing necrotizing fasciitis ultrasound for a case that suspected necrotizing fasciitis to find something in support this diagnosis, not to rule out to rule out that. So we don't use ultrasound for exclude the necrotizing fasciitis. We need to keep this one in our mind. And CT MRI is more sensitive, more specific, but sometimes they are not available for us to do it, or the patient is not that stable patient to let them to leave the department to go to the CT and MRI. So what we can find, you may find in ultrasound in cases necrotizing fasciitis. So again, we can find subcutaneous thickening, fascia fluid, and subcutaneous air with dirty shadowing. So when we should suspect that this soft infection, maybe it is necrotizing fasciitis. One of them is fascial fluid. If you find fascial fluid over the fascia layer more than 4 mm, if you find such a this fluid, the case is suspected as maybe necrotizing fasciitis. So it is very important to check over the fascia to see if there is a fluid accumulation or not, and what is the size. If the size more than 4 mm, it looks like maybe it is fasciitis necrotitis, and we need to be more invasive, start your antibiotic, and do more sensitive modality of imaging to rule out or rule in necrotizing fasciitis. Another finding that we can have in necrotizing fasciitis is dirty shadowing. So we can have some air in subcutaneous layer with shadowing, but the shadow is dirty shadowing. So what is the difference between dirty shadowing and the normal shadowing? If you see here, there is a calcification. This calcification also has a shadow, and here the airs also they have shadow. But what is the difference between this shadow and this shadow? Here is very black and clear shadow, but here it is dirty shadowing. So in this way, we can suspect it is fasciitis necrotizing. So necrotizing fasciitis. And if you find this one, so you immediately get involved, the surgeon, and start your antibiotic, and prevent from bad outcome. Let's take a look at this image. Looks like cellulitis again, redness, and there is a small puncture here, so could be from an IV line. So if you just consider this one like simple cellulitis, you may miss something else also. They did an ultrasound for this case and they found vein septic thrombophlebitis. So there is echogenic lesion inside the vein lumen, and there is some prevascular inflammation, and there is a no flow on color Doppler. So when you are doing the ultrasound, you need to check peripheral veins also. In some cases that is suspected, maybe it is thrombophlebitis. Another case, if you see here, there is a redness. So is it just cellulitis, abscess formation, or something else? They did ultrasound also for this case. They found abscess in this location, anatomical location. Let's review the ultrasound together. It is the derms and hyperderms, very tiny and echogenic. Here it is subcutaneous, is the fascia, and here is the muscle. So where is the abscess? Inside the muscles, the muscle's belly. So it is pyomyositis. So the management of this case is completely different from the case with simple cellulitis or simple abscesses. With all these good things that we discussed about the ultrasound, but our friend the POCUS has some limitation. It is really dependent who is doing the ultrasound. It's operator dependent. So that's why we need to learn and to practice to improve our skills to be the most efficient physician that you are using the POCUS. If you are not that skilled POCUS man and trust your study, you may miss something. That's why you need to practice and to review your images with someone more expert from you. and even with the radiologists, the images they will send for us, I'm always reviewing what I found in what I found in my case and what they are reporting and what they detected. In this way, maybe we can learn much better. And we can miss very subtle cases also, very early stage of abscess formation. Necrotizing soft tissue infection complicate the detection. We cannot do the scan easily for them. And ultrasound, it is just to scan what we are looking for. If we don't check whole the lesion, we don't map whole the lesion, so we may miss some abnormality and some pathology. So that's why it is very important to scan all surrounding that lesion, that cellulitis that you find. And it is very difficult sometimes to differentiate between the fluid. So sometimes it's hematoma, it's seroma, or it is abscess. It's very difficult sometimes to say what is this, and that's why consider clinical context is very important, and always review the mimics. So what we find, maybe it is another thing. That's why we need to use the color Doppler and other plans just to make sure it is really abscess or lymph nodes or maybe sort of an aneurysm. So what I usually do for my cases in emergency room when it comes to a patient with soft tissue infection. The patient usually they present with redness, warmth, tenderness, swelling, and the fever. The first question always I'm thinking, is it just cellulitis or something else? And then I will go with my POCUS. I choose my probe based on what is the case, the body habitus of the patient. Am I scanning some location, some anatomical location like thigh, buttock, or I just wanted to scan finger and toes. So I use different technique and different probes, and then always I'm scanning in two plans, sagittal and another plan also. So use a lot of gel to have a better optimization. I'm using color Doppler always to rule out the vessels, the pseudoaneurysm, just to guide me when I'm doing the incision to avoid any unexpected injury to the vessel, to the nerves. And then I will interpret my finding considering what I have in our clinical finding. It's just skin thickening and cobblestoning, so it is cellulitis. So I will start my antibiotic and follow the patient. But if I found fluid pocket, posterior enhancement, swirl sign, squeeze sign, so it is abscess. And if it is more than 4 mm, half centimeter, so need to be drained. So I may go for drainage, or I may ask the surgeon to help me in this case. If I found facial fluid more than 4 mm or gas formation in subcutaneous, so it is necrotizing fasciitis, more severe case, I need to be more invasive in this case, start antibiotic with good coverage and doing some more investigation just to confirm it is necrotizing fasciitis or not. And if I found any abscess inside a muscle, so it is pyomyositis, and this one needs different approaches and different management. So soft tissue POCUS, it is very fast way to see what our hands cannot feel. Thank you very much. I'm really happy to take your question. And please go to the Master Academy, and it is my LinkedIn also. If you have any question, you can contact me there. Thank you very much.